The FibroScan is basically it's not something that's very old, and the FibroScan itself, the name is actually wrong. It's the trademark from a company in France called EcoSense. And I just want to let you know that they make lots of money. I can see that here. So the little FibroScan on the right-hand side, the cost is equivalent to that car down bottom. So it's pretty expensive, and a lot of people try to duplicate it, and it doesn't work. So anyway, it was approved by FDA only about 10 years ago. And we got our FibroScan in Vancouver Hospital, I think around 2015, 2016. And so what the FibroScan does, it gives you two measurements. One of them a bit more useful than the others. The more useful measurements see how stiff your liver is, how hard it is. And the other measurement come with software upgrade, see how much fat you have in your liver. So give you information that before that you need a liver biopsy. So of course nobody wants a liver biopsy. And so therefore the FibroScan basically the stiffness part, they use a sound wave, a very focused beam that goes in the liver for about 4 centimeters, which gives you a stiffness measurement that goes anywhere from 3 to 75, and normal is less than 5 to 6. And you have anywhere like 14 or 15, for sure, you probably has cirrhosis. And there are some false positives. For example, if you eat before the FibroScan, it'll give you a higher number. And there are other ways you can measure liver stiffness, but they are not like so readily available. You can measure by MRI, but of course MRI is difficult to get. And there's also an internal control in that we measure not only once, you measure 10 times and look at how much dispersion the readings are. If the dispersion is tight, that means the measurement is more reliable. Okay, so the actual definition of F4 fibrosis or cirrhosis depends on the condition that you have for the FibroScan. For the purpose of fatty liver, it doesn't work, this thing, pointer. Does it work? No pointer. For purpose of the fatty liver, if you got a fibrosis score, elastography score about 12 or so, or 13 is already cirrhosis, but you have a different condition, the numbers will change. So, and the other measurement, which I think, in my opinion, the fat measurement is a bit more not so accurate sometimes, and also gives you a number. The normal fat for liver is less than 220. Is a sound-wave type of number in physics. It's decibel per meter, and you're anywhere like close to 300 is really significant. So in one measurement, we can get two things. And the FibroScan is not that widespread in BC. I think that they only have a few. I think that certainly less than 10 in the whole province. And we don't get there is no MSP code for doing a FibroScan. Basically, we do it for free. And all the liver patients that come through Vancouver Hospital, I'm sure for St. Paul's, they will get a FibroScan or any other major places. So this example of a patient who has pretty well close to cirrhosis, and the fat is really high at 315. The elastography score is 12. Okay, to give you this kind of thing, that's what it looks like. That's what we do when we do the Liver Beware project, is to go out in the community and check on a bunch of population and see how many people in the population has fatty liver, how many has significant fibrosis, so forth. The project is still ongoing, is supported by many of the donors and also London Drug and many people. So if you're interested, you can sign up. Do anybody has signed up and check it? No? Well, quite a few of you. Have you got fatty liver? No? Little bit. Okay. All right. So why this fatty liver is important, because you got to look at the landscape of liver disease in general, open our eyes to the world. And basically, hepatitis B, it's got about 300 million people carrying the virus. We have a cure. We don't have a cure for Hep B, where we have medication that can keep it under control very well. Hep C can actually cure. For these two conditions, the problem is that getting the patient to get treatment. And for fatty liver, it's probably the same kind of deal. Like a lot of people have fatty liver, they don't recognize it. And and comes in too late. One thing about fatty liver clinically that I can tell you, that's my own perception, okay, it's not anybody's perception. If you come to see me with fatty liver when you are like 25 or 30 years old, I will basically bash on your head to do something about it. But let's say you're 75 and you got some fatty liver, not much fibrosis. I'll probably let you go. I probably won't say anything to you. Carry on eating whatever you want. Okay. Enjoy yourself. What the heck? No point. Because fatty liver takes many years to get into trouble, and so that it will probably exceed the lifespan of a family doctor. For example, I've seen fatty liver usually in around 70s or more, so that the GP may not pick it up or retire already. So it takes a long time. Usually, it's a long-term thing, unless you do something bad on top, and you have drink a lot of alcohol or something, or you got Hep B on top, that kind of thing. So this slide you've seen before. I just want to illustrate the thing that we do not know. When you have normal liver, and then the first thing is that for fatty liver, you have increased hepatic free fatty acid. There's a number one criteria. There's some genetics involved, but basically a lot of this are other things like the weight increase, diet, and so forth. And from just increased fat, it's totally reversible, as we heard. But however, for some reason that we do not know, there's probably many factors involved that when the excess fat actually causes inflammation. And this is called NASH, or somebody call it MASH, because it's got a lot of association with like other things, diabetes and high blood pressure and so forth. And that is still reversible. By the time you get to cirrhosis, it's partially reversible. And cirrhosis is a term that we throw around, but I think that Dr. Kim and other surgeons may agree with me. There are some cirrhosis that actually in the early stage you can get better by removing the offending agent. And it's not like totally irreversible. We've seen that in hepatitis B, we got cirrhosis, you treat them, and then the cirrhosis actually got a lot better, go down one fibrosis stage or two. In any case, the transition from just too much fat to actual inflammation is something that we do not know exactly what's going on. There's probably many factors involved. And this is the big mystery in the research in fatty liver. So basically, I think there's a lot of people with fatty liver that you don't have to be scared about it because the chance of people fatty liver to cirrhosis is actually quite small. And we know that the BMI more than 30 over time, you can see that over the last 2 or 3 decades, it's like huge increase, some places more than others. I think that's why when you watch the Korean, when I watch the Korean Netflix series, I don't see anybody really too fat over there. Really slim. When I go to Asia to buy clothes, I'm okay. I'm the extra large. I'm not extra large. They're so different. So beware when you order stuff from China. What's the website, Temu or something? Make sure you order one size bigger than you normally wear. Otherwise, it won't fit. Okay, but Canada is up there. So I think in terms of numbers, this slide is difficult to read. The actual inflammation of the liver has a different scoring system on biopsy than another that I don't have to go in detail, but it actually impacts in terms of clinical trial what you want to achieve. So number one, increase free fatty acid in the liver. Some genetics, there are some people so-called lean fatty liver. They're actually really skinny. And they come and sit in the office and say, Dr. Kwan, are you sure I got fatty liver? You look like you're bigger than I am. Look at your tummy. You're trying to suck it in. It doesn't work. You see, you got fatty liver. I said, no, I don't get fatty liver, but there's some genetics involved. And so anyway, in terms of number, this is what happens. About 30 or 40% people walking around in the room. If I got FibroScan and do one for you, probably find 30% or more get fatty liver, but actually getting NASH is only about 10%. People actually get inflammation and also cirrhosis less than 1. So, don't be afraid when you got fatty liver or your GP do an ultrasound on you and said that your liver is echogenic and got too much fat. Once your liver cells have 30% or so more fat, then you can actually see an ultrasound. A good ultrasonographer actually can tell you how bad it is, severe fatty liver, mild or moderate. So anyway, the drugs that you talk about in the past, I've heard somebody ask a question to Dr. Tam about the drug treatment for fatty liver. The research, in terms of all the research I've been involved with clinically, they always want an endpoint. What's the endpoint for fatty liver? Basically, is one fibrosis stage reduction, usually over a year and a half, and more than 2 points reduction in the inflammatory things that you can see on the biopsy without worsening the fibrosis. That's the endpoint that the drug company always use. And basically, it's a short-term thing. They usually try the drug for a year and a half. It doesn't work and stop. And so this is a very busy slide outlining the difficulty in terms of research in fatty liver, and that there are many things involved when you go from just doing too much fat to actually inflammation. And and therefore, it explains why so far we don't have a single drug that works extremely well, because so many things are involved. And I think that more than 400 clinical trials are ongoing in the world. Every drug company knows that this is a gold mine. You can find something that really changes from the inflammation back to just having fat or decrease the fibrosis stage is a big time, money maker. But the thing is that I think most of the time, the thing that you can see from the slides later on, one single drug is not likely to cut it. I think you have to use a combination. So I'm going backwards, am I? No way. So it's just to show you a big failure. This is with Gilead, a US company down in California. They try to market a drug or try to research a drug that basically inhibits fibrogenesis. Sounds good, less fibrosis, better liver. But they fail to get to the endpoint that I talk about, and they have to be withdrawn after like many billions of dollars spent on it. So this is the one that somebody brought up, the new one that was approved by FDA in March, just a month and a bit ago. It's got different name, resmetirom, or there's a brand name. But you look at the fine print, you just look at the blue color. The improvement actually is not great. It's like look about 25 to 29% either improving the inflammation or the downstage of fibrosis stage. And you can see on the gray bar there is also some improvement. That's the placebo arm. Basically, what it tells you is that it confirms what we know from years ago. People do paired liver biopsies over 10 or 14 years to see what happened. You got fatty liver now. What happened after 10 years? On biopsies, not on FibroScan. And actually, some patients have become static, and some get worse, and some actually get better. So that's why you see the placebo, gray bar is quite high. And also, although they achieve statistical significance of p less than 0.05, but it's not like that 100% of patients with fatty liver improved with one fibrosis stage or improved the inflammation. It's only 20-some%. So therefore, I don't think that this is a be-all and end-all. And so now we got a drug for fatty liver. It's not the same as you got a drug for inhibiting the Hep B or cure for Hep C. It's nowhere near that level. So temper your, enthusiasm to go and buy this stuff, I think. So this medication is not cheap. In US, it's $47,000 per year. One pill a day. So I think the drug company, of course, they price in the research they have to do, the money they've spent to get it on the market. I don't think the BC Pharmacare is going to approve this anytime soon. So I don't think ever going to get it in BC with that kind of price. As I have struggled with treating Hep B and Hep C patients because of the high cost of the drugs, and the fact that anyone here from Pharmacare? Because I want to say something negative about Pharmacare. Pharmacare BC is probably the worst Pharmacare, whatever, equivalent throughout Canada. So they are the last to approve drugs that other provinces approve. If you remember, I think you're too young to remember all that. Say, okay, for hepatitis C, when we have effective drug for Hep C, there's those triple therapy with interferon and protease inhibitor and so forth, that it took the Hep C Society to tell the government, everybody approved that, Ontario, Alberta, that you don't approve this drug, we're going to shut down BC Ferry. You might not remember that. They actually was contemplating a march to the terminals and shut down the ferry. And the Pharmacare approved the next day, of course. So that's our story, Pharmacare BC. is very difficult. So I think that we're not going to get this new fancy drug on the thing. But in those days, when I struggled with trying to treat patients, the pharmacare don't approve. Okay, what do I do? So I go online, I search, I phone people, and I found that you can actually get drugs very cheap elsewhere in the world. The pharmaceutical company knows that if they price the drug in Canada the same as in Paraguay, it's not going to work. So in South America, for example, at that time the Hep C drugs, the price is about 1/10 of that in Canada. So anyway, so I found online, and I found this in India. Okay, I don't think they care about patent and anything like that. You can sue me all you want. Right? They actually make drugs all the time, even when you just approved by FDA, they still got a patent. They'll make it. So you can get this from IndiMart. You can go on India, INDIAMART. It's like an online thing. There's also another site called the pharmacychecker.com, and that lists all the offshore drugs that you can get. However, most of the time, or I say 99% of the time, you cannot get it shipped to Canada directly. You can get cholesterol medication, blood pressure medication, real cheap, but you have to ship it to US. You open the box over across the border in Bellingham. It's too far. You can go to Point Roberts, drive across and get it 3 or 4 times a year. Save you tons of money. I mean, yeah. So you can actually get this stuff, from India. You want, you gotta try it out. Okay. Okay. People are leaving. Time's up. Okay. This is it. So I just show you the examples that the weight loss. We talk about losing weight, right? The best way I can lose weight is I think I find, okay, Mr. So and so, Mr. So and so, you got fatty liver. You haven't lost weight for like 10 years. Your fibrosis score sucks. Okay, what can I do? To improve you. I can't lose weight. I eat, even I don't drink water. I drink water, I gain weight. Okay, that kind of hear that all the time. So what I say to them, okay, well, what I recommend you do is go to Malaysia, or Indonesia, put a bit of marijuana in your pocket, get on a plane, get through the custom. You won't get the death penalty because it's not hard drugs, just a bit of marijuana. What they do for people over there with this kind of offenses, not death penalty, they send you to an island. They ship you to an island, drop some food off. It depends on how bad how much drugs you're carrying. Yeah, I pick you up after 3 months or 6 months later. Guarantee you will lose weight, 100%. Yeah, solve the problem. So this patient in particular, okay, so we can tell the importance of weight loss. And she came to see me. Her fibrosis score was 13 point something, and and what's the liver enzymes were up. But she listened to me. She actually go and do all the things she supposed to exercise big time. 70% of the ideal heart rate and so forth. And she lost about 18 pounds. She didn't, sorry, 18% of body weight, which is a lot. I think I tell people your target shouldn't be that ambitious. 200 pounds. I don't want you to lose 150. Maybe you lose to 10%. And you look at the liver test, it got all better. Fibrosis score get better. So it's real. Weight loss is important, big time. So I think that the Malaysian thing is good. So, and the other thing is that we cannot sometimes use the biochemical parameter to say how bad your liver is. This is a liver test a family doctor would do, your AST, ALT. And then this patient, got terrible fibrosis score, and she got liver cancer in the end because of the fatty liver, and the liver tests were never really up too much. Okay, and I skip all that, and then let's see. So 8 billion people in the world times 0.4% to 3%. I don't know. The number is very big anyway. I think for a drug company, I think that they have to now the clinical trials that we have at Vancouver Hospital is using just like the HIV in the old days. The first HIV treatment is only a single drug, 3TC, and then they use combination treatment, as you know. So the fatty liver, I think, will go down the route, probably because the mechanism is so complex. It's not that one drug can fix it. Now the clinical trials that we have are usually combination medication and different dosage and so forth. Okay. So I think that we have this Liver Beware program. We haven't analyzed the data to the end. We have checked about more than 3,000 people, or 4,000 now, close to 3,000 something. What we found was that there's a few things that about 30% of some of the population we check has too much fat. S2 is a fat indication. And actual fibrosis, actual cirrhosis, 0.9%, pretty close to all the published data. It's nothing new. But out of the 2,000 something, when this was presented in DDW, that the number of patients who actually need some intervention is 114. If you enlarge it to the whole province, it's a big number anyway. And I think that the last slide is that for some reason that we did some subgroup analysis that the East Indian population, we try to balance it so that the study is like 1/3 Asian, 1/3 Caucasian, I think something like that. I don't know. They try to balance it to the demographics of the lower mainland. I think the out there when you're doing Surrey and London Drug help us a lot that the fatty liver incidence is quite high actually, more than the metropolitan Vancouver. Okay, that's all I have to say.